I want to thank the Society for the invitation to be here today and wave my Birmingham tie. It's truly an honor and a pleasure to give a talk on VATS where we are in 2016. I come from the Kingdom of Denmark, straight east from here, where VATS has been implemented extensively, as we have heard from René. I will direct my talk into these areas: adoption, why does it remain so low, surgical skills, increase in complex resections, how about lymph nodes today, perioperative management, academics, and the near future, what should we fear as thoracic surgeons. And then I've been asked to address the role of VATS versus thoracotomy in pulmonary metastacectomy. So, for adoption rates, do we need to rethink organization of thoracic surgery across Europe? The switch from maximal invasive to VATS has been going on for the last 2.5 decades, but the adoption, the take-on of this technology remains low. There's been an adoption gap that remains even in 2016. If you look at the data from the Society of Thoracic Surgery database, it appears that more than 40% of lobectomies in the US are done by VATS. But if you look at those who pay the insurance business, it's estimated to be about 15% across US, which is high and much higher than Europe. When you look at the cross-sectional survey that was published recently, more than 800 thoracic surgeons were asked about their approach for lobectomy, and more than 50% answered that they're using VATS or robotics. So that does not translate into the data we can take out from the ESTS database, where the 28,700 lobectomies and less than 10% were done by VATS. So something is not right, or it's just not caught up with the current status of surgical approach. I assume it's a lot lower than we think, and if you look at the French database, in a paper that is being accepted for publication in the annals but not yet in print, it's less than 5% of lobectomies in all of France that are performed with the VATS approach. So in the UK, this was the last picture I have where you were about 13-14%, but I was told recently that you have approached 30%, so it seems that Europe is dividing into a high-volume Northern European tradition and a low-volume Southern European tradition. In my own country, these are complete national data. The fraction of lobectomies that are performed with VATS just continues to increase, and last year was more than 60%. René is from Copenhagen, and in their group, they're pushing it to 80-90%, but on average, the whole country, it's just 60%. Maybe it has something to do with the fact that the thoracic service in our country has been centralized over the last 25 years, and the fact, not only the fact that outcome improves when you centralize, but the fact that you can do a lot of cases has probably been the reason that VATS has been implemented so easily. We only operate for lung cancer in 4 university hospitals, and that contrasts with other countries of similar size and population. For instance, Switzerland, that has a lower incidence of lung cancer and much more units that are doing lung cancer surgery. So they don't have a lot of cases to practice on, and that is probably one of the reasons that VATS is not catching on so quickly. In Holland, they do lung cancer surgery, I think, in 40 different departments, and some have very low volumes of lung cancer resections. But surgical skills continue to improve, and when you read the literature, there's several papers in every journal that address the new technical skills. The days are over where we consider this a minimal invasive approach. The days are over where we do a simultaneous stabling of the hilum. We all agree that a true VATS lobectomy is a strictly monitor-based, no rib spreading, and complete anatomical dissection. But the number of ports remain controversial. This is a picture I have from Rob McKenna in Los Angeles, and he is one of the most experienced VATS surgeons, and he continues to use 4 ports in all cases, well, almost all cases, and his patients are doing very well. On the East Coast, the 2-port approach has become very popular from Duke, and recently we have all listened to Diego with the uniport approach, and it's spreading like fire across the thoracic community. I'm a very good friend of Diego, and I tease him a lot because I ask him if it's better or if it's not better. I'm suspecting that intercostal instruments can actually angulate and hurt the periost of the ribs, and this torque can cause some pain. So what you gain from minimal access, you lose from instrumentation in that port. And just for fun, I tease him when maybe can you put the... Are you advancing to the same slide, or should I? I don't know what happened, but we'll quickly catch up. When I asked Diego about the clinical data, there's very little. And when I asked here we go. Okay, sorry about that. My iPad, what is your opinion about Uniport? The spelling control says unimportant. But truly, you have to ask yourself if a thoracic surgeon is less better when the data is not there. And this is my mentor who said when we introduced VATS lobectomies 10 years ago, Peter, I can do an open lobectomy with my left hand on the back. Is that necessarily better for the patient? And we should really address the issue if going more minimal is better if we don't have the data to support it. And it appears at present that we don't have any substantial evidence that uniport is better than multiport VATS. There may be improved pain scores, but we really don't know. So, the increase in complex resections will be addressed by René. I will just touch upon the fact that we take on more difficult cases, we take on more patients with higher age and more comorbidity. We also have advanced or have used the technique in infants, so in that regard it's more complex. Bronchoplasty has been published as case reports and small case series, but not to a large extent. You know that it's possible to do even a vascular sleeve resection, and some have actually even resected part of the superior cava. It's not for everyone, and even the most experienced surgeons only have a very, very limited number of sleeve resections in their series, so perhaps this should not be the standard approach for a sleeve lobectomy. Sublobar resections are gaining popularity, and we have a lot of comparative studies that suggest that challenge the 95 paper by Ginsberg that subsobar anatomical segmentectomy may replace the standard lobectomy. But we need the data from the North American CALBG trial and the Japanese Western Oncologist Society. It's definitely much more complex. If you are not used to VATS lobectomy, adding on the segmentectomy is adding on a layer of complexity. Lymph nodes are okay in 2016. There's been a lot of debate over the last 20 years if lymph nodes sampling or clearing is equivalent, but I think most of the papers in the last 10 years have addressed this, and it was sort of a surprise when Daniel Buffer reported that the lymph nodes end-stage migration was significantly higher in thoracotomies than in VATS, and that was of concern if you left behind positive lymph nodes when you used the VATS approach. We duplicated their study with the Danish national trial, and we saw an equally difference between open and minimal invasive surgery, but because our registry links with survival for the entire population, we were able to demonstrate that survival is actually better if you have a VATS procedure compared with the thoracotomy. The advantage of VATS is lost when you do a multivariate analysis, but equally important, it's not less. suggesting that we do not leave behind positive lymph nodes just because we do it with a telescope. Perioperative management is something that we will hear a lot about in the future. The well-known important team player with the fact that you can't do VATS if you can't have an anesthesiologist who can do double lumen intubation holds true. But you'll see that in the future, a lot of our surgery is done as an awake procedure where the patient is heavily sedated but breathing spontaneously. And that it will be a challenge for VATS. Diego has shown the way with awake VATS lobectomy, and it's done routinely in many centers in China. We have had awake thoracic surgery for years, but not to the extent that we do now. And this is a picture of film from Diego in Corona, where you can see the whole operating field moving during the dissection, which may be considered the upcap of thoracic surgery. What about outpatient thoracic surgery? It's already routine in sympathectomies, mediastinoscopies, and small lung procedures. But lobectomy, would we even consider to discharge a patient on the day of surgery? I doubt if it has any clinical benefit. But if you look across to Asia, there is a series of open cardiac surgery where they closed the ASDs in a group of patients and discharged them in the same day. And if you read the abstract, the hospital stay is listed in minutes. Academics is still not impressive in 2016. We know that from the literature that there are potential benefits from VATS lobectomy. We have challenged the last one and shown that perhaps it is a problem with selection bias in most of the papers. And this is true for almost all of the literature. We have now 1,600 papers as of yesterday, and we have to acknowledge that there is a risk of potential selection bias when you continue to publicate the non-randomized trials. In fact, when we look at thoracic literature, and this in particular, it's just not good enough that the thoracic community, surgical community, doesn't go together, stand up, and recruit patients into the same trials across borders and across continents and across political societies, and leave behind all political disputes. When there is a surgical procedure that is considered equivalent, I think that a randomized trial should be encouraged. We cannot rest our case on continuing publications of non-randomized data, even if we do the best of statistical manipulation. It's just not good enough. So a randomized trial should be encouraged, and we definitely need a multi-center, large-scale trial to have this going. We should move away from eminence-based practice, and we should move towards evidence-based practice in thoracic surgery. There are 7 small trials in the literature. That's 6. These are the 4 well-known, of which Kirby really only showed a difference in complications, with primarily more air leak in the VATS group. Sugi showed no difference in 5-year survival, but no clinical data. Craig showed some difference in cytokines that disappeared within a few days. Shigemura randomized between 2 types of minimal invasive, not really open, versus VATS. Then we have an interesting Chinese study that has not been cited in the English literature, and it's impossible for any university library to get hold of it, but it's in PubMed. And apparently they randomized 47 patients and found a significant difference in pain scores and quality of life. The German trial investigated if lymph node clearance was adequate and found no difference. And the last trial will be published soon, I'm very pleased to say, from our institution, where we screened 1,000 eligible patients, and 772 were eligible, and managed to randomize 206 into anterior thoracotomy or VATS for stage 1 lung cancer. And we were able to show a benefit of VATS, and it will be published in the near future. The near future of VATS is of concern is not so much that we're being challenged by the industry to use robotics, because the number of centers that are using robotics worldwide is still at a very low level, primarily 3 centers in the United States. These are more than 3,000 Da Vinci systems, but they're used primarily by other specialties. And the fact that we have introduced smaller telescopes with high definition and 3D technology, and the fact that we're moving towards fewer ports in VATS, makes it difficult to see that robotics has a role in the near future. Natural orifice surgery is not, in my binoculars, coming this way. You can do cholecystectomies and nephrectomies through the transvaginal approach, but not so much in thoracic surgery. There's a paper on transvesical, transabdominal, transdiaphragmatic lung biopsy, but it's in a dog model, and so is the transumbilical lobectomy, also in a dog model. There's a paper on transtracheal thoracoscopy, and they have also done some transesophageal thoracoscopy where the access actually heals very well, but I just don't see that coming in the near future. What I see coming in the near future is the SBRT, which is a challenge to us as thoracic surgeons for the early stage cancers that we like to do with the VATS technique. If you accept propensity scored papers in surgery, you will also have to accept propensity scored papers that compare surgery with SBRT. And in this paper from 2015 in lung cancer, there's no difference in 3-year survival between those who have SBRT and lobectomy. These are data from the randomized trial that were published last year in Lancet Oncology, where these 2 trials that terminated early because of slow accrual, they gathered the patients, and they were also able to show no difference, or actually a difference in favor of SBRT for early stage lung cancer. And these patients were eligible for surgery. When it comes to pulmonary metastasectomy, VATS shouldn't have a role according to the guidelines. As a diagnostic procedure, it's generally accepted, but not for therapeutic purposes according to the guidelines from 2010, but things have changed since then. And when you ask in the thoracic community, some 40% of thoracic surgeons still use VATS with therapeutic intent. The problem is that non-imaged nodules cannot be palpated when you are hampered by the limited access through the ports. It's well known from a lot of case series and case control studies. So we challenged this concept because we now use the most advanced technique, and we have now modern CT scans and PET scans in all patients. And we decided to do a blinded study in the way that we had 2 surgical teams operate on the same patient. So we took the patients that were scheduled for pulmonary metastasectomy and started out with a VATS procedure, then switched the surgical team that continued to do a thoracotomy. And it illustrates very well that the 140 nodules that were visible on CT, only some 87% of them were palpable during the VATS procedure. So not all patients are eligible for metastasectomy with VATS, even in 2016. But what was of more concern is that we identified some additional nodules that were not seen on the CT. So even at 2016, with the most advanced 3D equipment, most advanced HD equipment and experienced VATS lobectomist, we still cannot identify all nodules, and those we see we cannot reach. And when we are satisfied with the VATS approach, we overlook additional nodules, and a substantial number of these are malignant. Whether this has any implication of survival, we really don't know. Whether this is a surgical disease, as Paul von Scheel said, we don't know. As Tom Treasure suggests, we don't know. What we know is that if we intend to take out all the nodules, if we think this has any implication of survival, we should take out as many as possible in the beginning. Because some of these some of these metastases, they metastasize to the mediastinal lymph nodes. At least that's what we think. We really don't know if it's the lymph node that metastasizes or if it's the primary tumor that also metastasizes to the mediastinal lymph nodes. But some 16% of the patients that are scheduled for metastasectomy, if you do an EBUS, they have mediastinal lymph nodes that are positive, and we consider these patients with disseminated disease and not surgical candidates. And with that, I want to thank you again for inviting me to... Oh, sorry, the last paper, sorry, very important. The recent review published in the Interactive Journal of survival is very, very interesting, because what I was addressing is the problem if we leave behind lymph nodes. Now it appears that it doesn't show when you collect all the data from 6 trials and have actually an improved survival in the VATS group. If you take the poor trials out, the advantage of VATS is lost. But it's suggested in this paper that VATS is better for somewhat reason we don't know. Thank you.